Hello and welcome to the topic chest pain in the core knowledge module. Chest pain is a very common complaint encountered and you would most likely be dealing with this complaint on a daily basis. It is crucial to understand an easy stepwise approach to ensure important aspects are not overlooked at the same time a working diagnosis can be reached soonest. Let's look at the stepwise approach we were talking about. First of all, verify the symptoms by patient's own words. Attend to the correct patient and verify the patient's name. Ask the appropriate questions, such as, "How are you feeling? I was informed that you were having chest pain. Point to me where you feel the pain. On a scale of 0 to 10, how would you score your pain? How would you describe the pain? And does the pain radiate anywhere else? Were you experiencing the pain at rest or while you were doing an activity? Is there anything you do that makes the pain better or worse? Are you feeling lightheaded or breathless or nauseated? And are you having any palpitations?" Take note, if the patient is in severe distress and pain, move on quickly to assessment. Now, let's look at correlating the signs. Look at the patient's general appearance. If the patient is restless or agitated, grimacing, having diaphoresis or clutching the chest. Reconfirm the GCS. If he's full or if he was able to answer your previous questions. Not full if he was not able due to poor eye response or verbal response. Gather patient's vital signs as the nurse places the monitors on the patient. You would want to look at blood pressure, the heart rate, regularity, the symmetry on both arms, oxygen saturations, and the respiratory rate. Examine the main areas such as the neck, the chest, and the lower limbs. What would you want to look at the neck for? You would want to look for raised jugular venous pressure, and this is seen in right heart failure or cardiac tamponade. As for the chest, you want to listen for heart sounds, looking for any abnormal heart sounds, murmurs, or crepitations and rhonchis. Lower limbs, you'd want to look for swelling. If it's present in both lower limbs, consider heart failure. If one lower limb is affected, you may want to consider deep vein thrombosis. Next would be the bedside tests. These tests are done with the help of ward nurses. At least one large bore intravenous cannula needs to be inserted. A 12-lead ECG followed by serial ECGs, which are at least 3 ECGs done at an interval of 5 to 10 minutes. And oxygen supplementation based on the oxygen saturation seen on pulse oximetry. Now, this is a flow on oxygen supplementation therapy. It is referenced from the British Thoracic Society guidelines. Begin with titrating oxygen up or down to maintain the target oxygen saturation. This flowchart shows the available options for stepping dosages up or down. The chart does not imply any equivalence of dose between venturi mask and nasal cannula. Allow at least 5 minutes at each dose before adjusting further upwards or downwards, except in major sudden fall in saturation, which is more than 3%. Once your patient has adequate and stable saturation on minimal oxygen dose, consider discontinuing oxygen therapy. Seek your senior's input as soon as patient requires more oxygen. Next would be instant lab tests, and these would include cardiac enzymes such as CKMB and high-specific troponin I. If raised, most likely it is an acute coronary syndrome. You'd also want to do a portable chest X-ray to look for pneumothorax, pneumonia, and widened mediastinum. After confirmation by the medical officer, if there's a high suspicion of pulmonary embolism based on the Wells score, you'd want to send a D-dimer test. If it's low or negative, this is most unlikely to be pulmonary embolism. If it's likely, you may then want to proceed for a CT pulmonary angiography. Stay with the patient until your medical officer arrives. Then you may expedite the transport of blood samples to the lab while ensuring there's always a doctor by the patient. Always reassess the patient with a repeat of the steps above after measures have been taken by the medical officer. Now, these are the list of life-threatening causes of chest pain. Acute coronary syndrome, including unstable angina and acute MI. Pulmonary embolism, pericarditis with tamponade, tension pneumothorax, aortic dissection, and esophageal rupture. Attached here is the ACLS algorithm to the approach to chest pain in specific acute coronary syndrome. It is an important algorithm to understand. A quick tip, you may save the algorithm as an image in your device to be referred to whenever needed. If you notice closely, the immediate step upon patient assessment is to carry out the MONA, M-O-N-A. M for morphine or analgesics, O for oxygen, N for nitroglycerin if needed, and A for aspirin. Concurrent assessment has to be carried out while awaiting for lab and X-ray results to be ready. An immediate bedside test that is very useful here is an ECG definitely. ST elevation MI is treated with immediate reperfusion measures which can include primary coronary intervention PCI or fibrinolysis. High-risk unstable angina or a non-ST elevation MI is treated with medical therapy and monitored closely with early reperfusion therapy planned. Low or intermediate risk ACS patients are subjected to non-invasive diagnostic tests such as exercise stress ECG or echocardiogram. We have come to the end of this topic. Thank you.